webinar, SBIRT in Action, Implementing and Delivering SBIRT in New York State STD Clinics. We have 3 presenters on the webinar today. The first is Shirley DiStefano, who's the project manager for the New York Screening, Brief Intervention, and Referral to Treatment grant for the New York Office of Alcoholism and Substance Abuse Services, called OASAS. She's been a project manager and evaluator for several federally funded grants for over 25 years. Also presenting is Brett Harris, Doctor of Public Health. She's the project evaluator of the federally funded New York SBIRT Cooperative Agreement, which delivers SBIRT in STD clinics and tuberculosis chest centers in New York City and emergency departments, and she also works with a federally qualified health center. Megan Roberts, MPH, is the Director of Special Projects for the New York City Department of Health and Mental Hygiene Bureau of STD Control. In this capacity, she oversees implementation and evaluation of a SAMHSA-funded project to deliver substance abuse screening, brief intervention, and referral to treatment services in STD clinics, as well as the Bureau's outreach and training activities and adolescent sexual health programs. So thank you, faculty, for participating today. I am now going to go into the poll questions here. We ask these questions at the beginning of each session just to get an idea of who our audience is. Now, this one, we want to know what field you're in. Are you a counselor, therapist, social worker, or counselor? Are you a nurse, nurse practitioner, physician, or physician assistant? Are you a program or unit administrator, university student, faculty, or other? And if you're on others, we would appreciate you putting that information into either the chat or the questions box, and that way we'll have it for our records, because it's always interesting to see who makes up our audience here. Okay, looks like we have a good representation now. I will close this poll and then we'll share it. And for our presenters who probably can't see this, 46% of the attendees today are counselors or therapists or social workers. 15% are nurses, nurse practitioners, physicians, or physician assistants. 23% are program or unit administrators. We don't have any students or faculty from universities, and we have 15% other. So thank you for that. I will hide that, and we'll do the next poll. Okay, what field do you represent? Are you in mental health, addictions, public health, education, or EAP? Now, for these polls, we're only allowed 5 offerings here for answers. We would also like to know if you're in public health, and you can put that also in a chat or the questions box, so we'll have that information. Okay, thank you. I will close this poll now and share the results. Okay, today we don't have anybody here in mental health field. 50% are in addictions, 38% in physical health, and 13% in education, and no EAP. Thank you. Now these next couple are going to be really easy because they're just quick yes, no. So, do you currently conduct SBIRT interventions, yes or no?
No.
Okay, thank you. I'll close this and share the results. Do you currently do SBIRT interventions their SBIRT services, and 39% yes, and 61% no. Thank you. And second to the last one here now. Okay. Is your agency currently using SBIRT or offering the services, or will they be offering them in the future? Okay, thank you. I will close that one and share. This is nice. It's so we have 82% their agencies or organizations are currently using or will be going into using SBIRT services, and 18% no. Thank you. And here's our last question. And this has to do with the webinar today. Does your organization or clinic offer STD services in SBIRT? Okay, thank you. I will, oops, sorry, excuse me. I will close this poll and share this. And presenters in the audience today, 56% say yes and 44% no. Okay, thank you very, very much. We will keep that all in our records now, and now we're actually going to start a webinar, and I'm going to turn this over to Shirley DeStefano and Brett Harris. Just a moment. Okay, so just click that, show my screen. Okay, Shirley, you're going to show, yeah, just minimize this screen. There you go. And then put it in the slideshow mode. Yeah. Okay, you can put it in the slideshow mode, yes, from the beginning. There we go. Thank you. Okay, I'm going to mute myself now, and Shirley, you're on.
Thank you very much, Chris. Welcome this afternoon to everyone listening in. I appreciate your time. I want to say that, yes, we have many STD clinics throughout New York State. However, this particular topic will be dealing with the New York City sexually transmitted disease clinics, and they are part of our SBIRT project here in New York. So, oops, sorry, here we go. What we hope to accomplish today and hit on all of these topics is a very brief history on SBIRT for those who may not know about SBIRT, just to bring us into the same picture. We're also going to talk briefly about what SBIRT is, and that is the project that we have in New York and have had for some time. And then the majority of our time will be spent with Megan Rogers, who will be discussing the project and the efforts that have been going on in the New York City STD clinics. And that includes how they were able to integrate SBIRT into their clinics. She'll talk about the what happens with the service flow in those settings. And she'll also talk about their service delivery and the volume of clients they have. And most interestingly, she'll be able to give us some of the evaluation efforts that they've made both in the behavioral and the biomedical areas. Then at the very end, we will be discussing the SBIRT, which is the project services and data. So briefly, what we know about our field and where we have been in the area of substance use services is that we've been in two major areas. The primary prevention area, which is precluding or delaying in the onset of substance use, which is usually taking place with an adolescent population and doesn't necessarily translate into other age groups. And then, of course, the tertiary treatment, which is where we have actually focused a lot of our efforts for those people who are acutely and chronically ill with a substance use disorder. And this is costing much time, money, and it's very labor intensive to treat all of these patients. So what do we know about this historical model? This model of substance use doesn't recognize that there is a full continuum of substance use behavior. It does not recognize that in this continuum there are certain substance use problems that go unrecognized and undetected. And it also does not provide a full continuum of interventions. Again, we're having those at the very front end and those at the very end. So this means that there's been a gap all along in this model. And it doesn't look at what we know from epidemiological studies of how people actually drink in the United States. And if you look at this, what we call it the drinking pyramid, you'll see that people here, 35% are abstinent. They never drink alcohol. Another 37% are maybe low-risk users. That means that they do drink, but they rarely exceed some of the limits that have been set by organizations like NIDA and maintain a lower risk behavior around drinking. However, as we're getting closer to the top, we see that we have at-risk individuals who are about 24% of the people who were recognized as having both harmful and or hazardous, and they tend to drink regularly and exceed one or more of those drinking levels. Which we'll talk about later. But at the very top are the people, again, that we're used to treating, and that's only 4% of the total population that we're looking at. So if you were to look at the U.S. census of approximately 313 million people, you have at the very top of the pyramid approximately 1.25 million dependent, whereas in the at-risk group you have closer to 75 million, and moderate risk group you're looking at maybe 116 million. So very clearly this shows that there is a definite pattern of use and of risk that we would need to take into consideration anytime that we're working in this area. So I'd like to introduce my colleague now, Brett Harris, who will take us through the next set of slides.
Thanks, Shirley. So, we talked about, providing prevention and treatment, but so SBIRT is a paradigm shift. So we're trying to recognize really the whole spectrum of use. So our new view here is to recognize that people are using at all levels of the pyramid that we just showed. So how are we going to treat substance use problems? How do we identify them? And how are we looking at it? So is it just people that are dependent, or is it people that are low-risk drinkers or risky drinkers? So the primary goal of SBIRT is to identify and effectively intervene with those who are at moderate to high risk for psychosocial or healthcare problems related to their substance use. So we're not looking for people that are dependent, but we're looking for those people who are at risk, that 24%, to provide, first of all, to identify them with screening, and then to provide brief intervention on site while the patient is there to receive health services, and if necessary, provide a referral to treatment. However, we can't forget that there's a large number of low-risk drinkers and abstinent people that are abstinent and do not drink. So this model also recognizes them and provides a universal screening just to, in this sense, provide positive reinforcement, encourage them about their good behaviors, and provide them information about what the risky drinking is to prevent. So here it is again, it's also prevention intervention to provide prevention to prevent the becoming risky drinkers or dependent drinkers. So just to give you a little bit more detail, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. So screening is a universal process. It quickly assesses use and severity and provides an algorithm for what type level of service to provide. So a brief intervention is a brief motivational and awareness-raising intervention given to risky or problematic substance users. This can be anywhere from 5 to 15 minutes, and it can be longer. But knowing the busy schedules in the clinics, 5 to 15 minutes can be 1 to 4 sessions. In our program, we offer 1 session, and then there's brief treatment, which is similar to the brief intervention. It's for higher level users, so you can provide more sessions, 5 to 12 sessions. It emphasizes motivation to change and client empowerment. And with the number of sessions provided, it gives the counselor time to follow up with the patient. And then the referral to treatment is to specialty care for patients with substance use disorders. So OASAS and Department of Health and Mental Hygiene in New York City have pretty long history of developing this SBIRT project and its need in STD clinics, and then the actual service provided in STD clinics. So in the late 80s through the mid-90s, OASAS implemented what's called Healthcare Intervention Services, or HIS, in hospital emergency departments and outpatient clinics to identify undetected alcohol and drug use. This service was provided either a brief intervention or a full intervention, meaning brief intervention plus referral to treatment. There is also, actually not on here, but there is an assessment, a needs assessment of alcohol and drug use in the New York City STD clinics, which underscored the need for the service, and is how we then moved forward with the project. With a pilot project in one of the highest volume STD clinic, which showed the need for the service, the acceptance of the service from both the clinic staff and the patient side. So with all this information and this experience, we developed Project Link, which was a 5-year SAMHSA award. It was a Targeted Capacity Expansion HIV grant. And that went into 3 STD clinics, and we partnered with the Lesbian, Gay, Bisexual, and Transgender Community Center and the New York City Department of Health and Mental Hygiene STD program. So the LGBT center staff were placed in the clinics, conducted SBIRT, and collected GIPRA data. Based on the success of this program, New York City Department of Health and Mental Hygiene used their own funds to expand SBIRT into 2 additional clinics, which it really showed how much the city valued SBIRT, because this was at a time, the economy was not good and there were not a lot of additional funds. And then following Project Link, actually near the end of Project Link's success and the underscored need led to OASAS and Department of Health and Mental Hygiene applying for and being awarded a 5-year SAMHSA grant, which is we're calling now New York SBIRT or NYCDOHMH 1. And this service, started out in 3 STD clinics, expanded into 6, and is now in all 8 of the full-time STD clinics, and actually all 8 of them. There's some part-time as well. And we also have services in Jefferson County near Fort Drum to reach the military population. It's 3 hospital emergency departments, 1 federally qualified health center, and 1 community mental health clinic. The goals of our project are to identify and offer early intervention for risky alcohol and other drug use, increase access to clinically appropriate intervention and substance abuse treatment, reduce risk of HIV and other STDs related to substance abuse, and improve linkages among public health and substance abuse treatment providers. So at this time I want to turn over the floor to our colleague Megan Rogers.
Hi, Megan, this is Chris. Did you mute yourself? Are you ready to go?
I think I'm unmuted, right?
Okay, good. Yes, thank you. Go ahead.
Sorry, folks. I don't know if you heard me, but I wanted to say thank you to Brett and Shirley for setting the stage, talking about the history of SBIRT. And I'm going to take us through what New York City Bureau of STD Control has done over the past number of years with implementation of SBIRT in our STD programs. So New York City Department of Health and Mental Hygiene Bureau of STD Control operates 8 walk-in STD clinics across New York City, and we see approximately 90,000 patient visits annually. We see a very diverse population. For the most part, the majority of our population are folks under age 40, although we see people ages 12 and up. Services are free, confidential, and available to anyone regardless of insurance status. And we offer STD, HIV testing, examination, STD treatment and counseling, emergency contraception, partner notification services. And since 2008, when, as Brett mentioned, we received our first SAMHSA award, we've been offering SBIRT services as well as crisis counseling and medical and social service referrals. We utilize an electronic medical record to capture all of our patient data, including SBIRT data, and I will go through that in a little bit more detail shortly. So I think we've long known in the STD program, anecdotally, as well as data-wise, that alcohol and drug use are associated with risky sexual behaviors. Certainly, alcohol and drug use can decrease inhibitions, and people might be more likely to engage in sex in general and unsafe sex in particular, thus increasing their risk for STD, HIV acquisition. And this is well borne out by the literature as well. So we know that substance use is associated with risky sexual behaviors and acquisition of HIV and other STDs. What we didn't know so much about back about 10 or 12 years ago was really what proportion of our clinic population had previous issues around substance use or substance abuse. And so we partnered, the New York City Health Department partnered with New York State OASAS back in the year 2000 to conduct a survey where we sampled about 700 New York City STD clinic patients to determine their history with substance abuse and whether or not they were currently receiving any treatment. And what we found was that 20% of our clinic population, this was a random sample, reported previous substance abuse, but only 1% reported currently receiving treatment. And so this really identified a gap for us that we felt STD clinics would be an optimal place to address. And then following that survey, we partnered again with New York State OASAS to conduct a feasibility pilot study in one of our STD clinics, and this was our Chelsea, Manhattan STD clinic in 2005. And we used the CAGE screening tool, and we found that 21% of our patient population screened positive for either a current or past substance use disorder. So as Brett mentioned, back in 2011 is when our current 5-year SAMHSA New York SBIRT grant began. And what we're currently using for screening tools include the audit and the DAST. So that's the Alcohol Use Disorders Identification Test and the Drug Abuse Screening Test. And we conduct a universal pre-screen in our waiting room, and the pre-screen is comprised of 3 questions. The questions really assess frequency and quantity of alcohol use as well as binge drinking. How often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And the binge drinking question is how often do you have 6 or more drinks on one occasion? And then the 4th question of the pre-screen is a question from the DAST, and that's a binary question, which just asks in the last 12 months have you used drugs other than those required for medical reasons. And so if a person answers any of one of these as a yes, then they screen positive for pre-screen positive. So what I'd like to kind of go through is for the full audit and DAST scoring thresholds, which services are offered and are available to people who score within different zones of the audit or DAST screening forms. So at the bottom, and this is somewhat similar to the pyramid that Shirley showed at the beginning of the presentation. At the bottom we can see zone 1, that's the first threshold, and that would be somebody who's either abstinent or drinking within recommended limits and also abstinent from drug use entirely. And zone 1 accounts for about, I would say, 65% of our clinic population. And zone 2, so these are people that we would consider full screening positive, somebody who is a zone 2 or above. And zone 2 comprises people that we would be considered low risk users. Either they have a risk of health or social consequences and they score somewhere between 8 and 15 on the audit and between 1 and 2 on the DAST. And typically these people are offered brief intervention services only, although if it's warranted or if they request it, they can also receive brief treatment that Brett described, which I'm also calling extended brief intervention. So brief treatment and extended brief intervention are, for our purposes, the same thing. And zone 3 is what would be considered high risk with harmful health or social consequences that are experienced as a result of drinking or drug use, and with an audit score of 16 to 19 and a DAST score of between 3 and 5. And those people in our clinics would be offered a brief intervention and extended brief intervention. And extended brief intervention, again, just as a reminder, what we offer is up to 12 sessions with a social worker or a mental health counselor. It's really targeted toward people who might have higher risk of use, but perhaps aren't really ready to accept a treatment referral yet, or just feel like they need to work through a behavior change plan around their drinking or drug use, or have other mental health concerns related to their drinking and drug use. And then finally, zone 4 is somebody who would be considered to have very severe hazardous use. There's already been definite social, health, or economic consequences that are experienced as a result of this use, and it's a score of between 20 to 40 on the audit and 6 to 10 on the DAST. And for those people, they would certainly receive also a brief intervention, and they would be offered a referral to treatment. If they decline the referral to treatment, then we encourage them to take advantage of the extended brief intervention as a way of helping them to address their use and potentially linking them with treatment or with other mental health or social services referrals that they would need. So this is showing our service flow in our STD clinics and when these certain tools are administered. As I said, the audit C and the DAST-1 pre-screen is universally distributed to all of our patients in all of the waiting rooms of our 8 STD clinics. And this is a self-administered paper form. What happens then is the patient would fill out the paper form, and if they pre-screen positive, they would be seen by an interventionist, and that interventionist would first administer the full screen to the patient, and then if the patient is positive on the full screen, they would conduct a brief intervention using motivational interviewing principles. And so just to reiterate, these principles include things like really reviewing positive and negative behavior consequences related to drinking or drug use, to assess the readiness to change of the person, and if the person is ready to change, to really develop an action plan for how this behavior change could play out. If the person receives a brief intervention and, as I mentioned, is eligible for extended brief intervention, then they're able to make an appointment with our social worker, and this is done on an appointment basis, which is in contrast to the rest of our services that are provided on a walk-in basis. And that's up to 12 sessions that they can have with one of our social workers or mental health counselors. Or if they score, as I mentioned, in zone 4, then they can get a referral to treatment if they choose to accept that. So just to be more specific, this is a general flow diagram of the STD clinic flow for our patients. When the patient enters the clinic, they receive a triage card, and that's the same time that they would fill out the pre-screen form. Then they bring their paper form to our registration clerk, and the registration clerk enters their patient information into our electronic medical record. At that time, the 4 questions on the pre-screen are also entered by the registration clerk into the EMR. And if the person's pre-screen positive, the patient is flagged. And I'll show you a screenshot of our medical record in a second to show you what that looks like. At that point, we try to determine when would be the most appropriate time for the interventionist to pull that patient and see them for the full screen and potentially for the brief intervention if it's needed. And we have three basic kind of tests. Basics are kind of visit types at our clinic. There's the HIV test only visit, whereby the person would initially see a phlebotomist for an HIV rapid test, and then the person returns to the waiting room. And for those people with that kind of visit type, the most optimal time for the interventionist to call them is when they're waiting for their HIV test results. So the interventionist calls the patient, and after the interventionist is done seeing them for SBIRT services, the public health advisor, which is our clinic staff, delivers the HIV results. One of the other main visit types, and I would say the vast majority of our patients do have an MD visit. They have an MD and an HIV test. The other visit type is just MD visit only. And what we really attempted to do when we first implemented SBIRT was it was important for us that we tried not to disrupt the existing STD clinic services. We know that when patients come to see us, their chief complaint is really around STD or HIV services or STD HIV issues, including STD symptoms. And so because they're coming into the clinic primarily for STD HIV services, we really strived to provide the SBIRT services during a time in the patient's visit when they would otherwise be waiting for results or waiting to see the doctor. So with an MD-only visit, what we would do is the interventionist would call the patient when they're waiting to see the physician. And then finally, as I mentioned, the vast majority of our patients have received both HIV testing and an MD visit. And when we would call them, typically, I mean, it varies a little bit from clinic to clinic in the flow, but the interventionist would typically call them when the patient is in the waiting room waiting for their HIV test results. At some clinics where we have a really high patient volume, such as our Chelsea clinic, interventionists will often call patients when they're waiting to see the physician because there's typically a long line to see the physician. But I think the take-home message is that we really, when we were implementing it, really strove to implement it in a way that didn't take away from the primary STD services that we were providing. So this is showing the pre-screen process on our electronic medical record. And as I mentioned, the patient registration is completed by the registration clerk. And what they do is they actually tick off these radio dials based upon the pre-screen question answers. And a score and a result is automated and locked at that time. And after that's done, if the person pre-screens positive, a banner appears on the top of the registration page that says, "Note, refer patient to the interventionist." And you can kind of see it, it's sort of under this red arrow here. And in addition to that, an asterisk appears on the triage page. And I'll show you that. So, sorry. So this is the triage page at the bottom of the screen here. And you can see the patient ID, a name, date of birth, and in the far right circled is the SBIRT column. And if the person's pre-screen positive, the asterisk appears there. And I'll go through, there's a couple of other denotations that could potentially appear there. I'll go through those in a second. And this is showing what our actual SBIRT, what the triage page looks like after the SBIRT intervention has been conducted. So once a patient has met with an interventionist and the information is entered into the SBIRT module, the asterisk turns into a check mark and the banner is removed from the page. And so these are just EMR workflows and notations that we put in place to ensure as much of a streamlined process as possible with making sure that we were able to see all of the persons that screened positive for SBIRT in the clinic. Very specifically, the symbols that could potentially appear on the triage page either include the asterisk if someone's positive, and then as I mentioned, once they're seen and the full screen is completed, that turns into a check mark. Additionally, if there's anything incomplete on the pre-screen, So if the pre-screen form is incomplete, the SBIRT column reflects the letter I for incomplete, and then the interventionist knows to pull that person and ask the pre-screen questions again. And then the other notation that could potentially appear in the column is a notation that says 6M, which stands for 6 months. And the reason that appears is because as part of our New York SBIRT grant, we are required to conduct 6-month follow-up interviews for the GPRA, the Government Performance and Results Act, with 10% of our sample. And so if that person was a patient that is enrolled in SBIRT and has been enrolled in a 6-month follow-up, and they show up at our clinic at any point in time for any reason, this 6M denotation will appear there, and that way anybody who works on the SBIRT team knows that they can pull that patient and conduct a 6-month interview at that time.
I have a question. Can I jump in here?
Sure.
Okay. There's actually 2 questions from one person, and it's right on this topic. How often do patients typically visit a clinic, and are patients screened on every visit?
Screened for SBIRT on every visit, I'm assuming?
Yes.
Okay. So I don't have the exact statistics to answer that question, although I could run them after the conference call, after the webinar, and get back to you. But I would say that we know, by and large, our clinics provide episodic care. They're walk-in services, and they're not necessarily considered a place that a patient would go for sort of a medical home. We know that approximately 65–70% of our patients are first-time visitors. So, therefore, about 35% of our patients have been to our clinics more than once. Those that have been there more than once, many of those people have been there multiple times over many years. How often they come, if they've been there more than once, really relates to how frequently they may have had a new exposure, or basically related to their sexual risk behavior. What I can say about SBIRT is that we do offer the pre-screen universally to everybody that comes into the clinic waiting room. If the person has previously screened for SBIRT, they're not required to fill out the screening form, and we know that approximately 75–80% of our patient population do fill it out. So there's about at least a 20% of our patient population that doesn't fill it out, and the vast majority of these people are persons who have been screened for SBIRT in the past. So, does that answer the question?
Yes, very well. Thank you.
So now I'm going to go into our service delivery results for New York SBIRT in the STD clinics. So these are showing data from February 2012 to June 2014. We began New York SBIRT in 2011, and we started implementation of services in February 2012. Since during this time, we had completed about 104,000 pre-screen forms at STD clinic visits, and about 51% of those, so that, for us, that was a very high proportion. Pre-screened positive, again, that's on those 4 pre-screener, 3 opt-in and 1 asked questions. And of those that pre-screened positive, we were able to see almost 22,000 people in person to complete a full screen. And of those that complete the full screen, it's about 67%, or about almost 15,000 that have received a brief intervention during that about 2-year period. And of those that received the brief intervention, about 1,100 have either been referred to extended brief intervention or referral to treatment, which was 8%. And this cascading graph is showing basically the same data, but as a cascade, because we felt like it was really important to kind of understand of our total sample, what proportion are we actually seeing and what proportion are actually getting referred into kind of ongoing services. So what we can see from this, again, 51%, and this is the number of patients, 53,000 pre-screen positive. Of the overall sample of people that completed a pre-screen, 21% completed a full screen, 14% were full screen positive and received a brief intervention, and 1% were referred to extended brief intervention or referral for treatment. And this is just a little bit more detail on what we've been able to provide for kind of extended services. So again, this is extended brief intervention up to 12 sessions. We've referred 1,100 patients to these services. And again, these are in-house services provided by one of our social workers, up to 12 sessions, and patients come back on an appointment basis. And what we found is that so far 263 unique patients have attended these EBI services, which is 24%. And for those that have attended, there's an average of about 3.5 or 4 extended brief intervention sessions that patients come back for. And as far as referral to substance abuse treatment, so this would be a referral to outside treatment through a New York State OASAS licensed facility, we have 50 referrals to formal treatment programs and a 42% linkage rate. So 19 people have actually entered substance abuse treatment, and we are missing data, tracking data on a small handful of patients. So I wanted to talk a little bit about sort of the demographics of the people that we see for SBIRT services. So this is showing age and gender distribution of patients who full screen positive and who receive brief intervention in our clinics during the same about 2-year time period. And what we can see just generally, so males in blue, females in green, and the age breakdown is across the x-axis. And what we can see generally is that the majority of people that we see for brief intervention are the younger population. So the highest proportions, 20 to 24 and 25 to 29-year-olds, and also that we see a lot of males. You might be wondering, well, how does this compare to our general clinic population? Is this any different? And what I can tell you is that the age breakdown is generally reflective of our clinic population. So we do, for SBIRT, we do see, majority of people in their 20s, but that is quite similar to the clinic population in general. As I mentioned at the beginning of the presentation, the majority of our clinic population are persons in their 20s and 30s, with the highest numbers being in their early to mid-20s. And then, what you can also see is that the proportion of people that receive BI tend to be more likely to be male. And I wanted to sort of better understand this, so I took a look at, for each age group, what was our clinic, just our general clinic census breakdown between male and female. And sort of interestingly, for persons that were in their late 20s and into their 30s, we do have about a 70-30 breakdown of clinic patients, male to female. And so it's not that surprising that we would be seeing a lot more males for brief intervention for SBIRT, because we see a lot more males in those age groups. But somewhat interestingly, for the 20 to 24-year-old age group, we do see about a 50-50 breakdown from male to female. And so it's likely that the prevalence of alcohol and drug use in this population of 20 to 24-year-olds is higher among males than it is among females. So this is looking sort of separately again at patients who were full screen positive and received a brief intervention in our clinics during the same time period, and it's just looking at a breakdown of race ethnicity. And what we have found is that the vast majority of our patients receiving BI, 48%, report non-Hispanic Black race, 25% Hispanic, and 20% white. And this actually is quite reflective of our general clinic population. So there don't seem to be dramatic differences in positivity, audit, or DAS positivity by race. So I'd like to spend a little bit of time for the next few slides talking about some both social and biomedical outcomes, evaluative outcomes from this project. And this is looking at self-reported behavioral and social outcomes using the GIFR tool. So I mentioned that about 10% of our sample for this service delivery receive a 6-month follow-up interview. And what we can see, that follow-up interview, depending on what type of service the person got initially, that follow-up interview includes, at a minimum, questions about alcohol and drug use, and then more extensive questions for people that have gotten EBI or RT services, ask about sexual behavior, mental health, other social services, employment, education, housing status, and it's about a 17-page questionnaire, so the list kind of goes on and on. But what I wanted to highlight were just a few really specific variables or outcomes that were kind of marked improvements over time. So the blue bars represent intake, so that's when people came in initially and filled out the questionnaire during their initial assessment and brief intervention. And then the red bars represent 6-month follow-up. So the ones I really wanted to point out was that for alcohol and illegal drug use, patients are asked the question about their alcohol and illegal drug use over time, and there was a 13% decrease in this marker. There was a 12% decrease from 90% to 78% in patients reporting unprotected sex. And then we thought anxiety was also a pretty striking result, that there was a 29% decrease from 70% of patients reporting experiencing anxiety at intake to about 41% that reported experiencing anxiety at the 6-month follow-up visit. So overall, those are some striking outcomes, and you can see that for the other ones as well, there were decreases and increases in sort of all the appropriate or the right direction that we would want to see. Now I'm going to talk a little bit about major biomedical outcomes that we've looked at thus far. And actually, this was an analysis that was using Project Link data. So Project Link was the initial 5-year sampler grant that we received. It started in 2008. And what we did was we took a sample of persons who were in Project Link. It was almost 7,700 patients that had screened positive for risky alcohol or drug use. And at the time, we were using the CAGE tool. So who had screened positive on the CAGE. And what we found was that initially we knew that just under half of them, those that screened positive, received a brief intervention. And this was only due to really not having enough staff to be able to serve the number of clients that screened positive. But what it did allow for is a good comparison group to really assess, was that brief intervention making a difference? We know that the literature out there shows that brief intervention can have a really positive impact on alcohol and drug use over time, or in particular alcohol use, as well as a number of other outcomes. But there really isn't any literature looking at the impact of brief intervention over time on STD and HIV outcomes. And being that we're an STD and HIV STD clinics, we wanted to really be able to justify having these SBIRT services. So what we did was we compared persons who received a BI to people that didn't, and we followed that sample and matched that sample of people to both our STD and HIV disease registries for a 1-year period following that initial clinic visit and that initial brief intervention. And what we were really looking for was to see, did people that got a brief intervention have a lower risk of STD or HIV over time compared to persons who were also screened positive but did not get an intervention. And what we found was some really exciting findings. We found that there was a significant relationship between patients who got a BI and STD acquisition over time. There was no significant association for persons acquiring HIV, but we feel that this had a lot more to do with the fact that HIV is such a rare event and a much more rare disease, so we didn't have quite the sample size to be able to make to prove an association for HIV. But we did find that patients who received BI were less likely to have a new STD infection than persons who had not received a BI over that year after getting their initial intervention. And we're pretty excited about these results. They're being written up now, and they should be hopefully published this coming year. We're the first STD clinic setting to do SBIRT in the country, as far as we know. And as far as we know, there aren't any other existing SBIRT outcomes showing any reductions in STD over time. So we're excited about that. I just want to present a little bit of patient and provider feedback. This is a quote from a patient saying, "I've been sober since the SBIRT intervention, and I've been meaning to write you for a long time to thank you for helping me. I still see my counselor on a weekly basis, and he's been integral not just in keeping me on the straight and narrow, but also in helping me deal with some of the crap that was behind my drinking. And then in addition to that, one of our staff members who is a doctoral candidate had conducted a project doing qualitative interviews with a number of our clinic staff, about 23 of our staff, mostly physicians and clinic managers, in what she calls kind of a retrospective qualitative analysis, to really get a sense of whether or not, what were some of the positive feedback that our clinic staff had, and what did they feel needed improvement or could be changed. And I just wanted to present some of the quotes from the physicians at our clinics about what they had to say about our program. So one of the doctors said, SBIRT staff will always identify the patient as someone they need to speak to. Even if the patient's not ready to change, they know that we have something here, meaning SBIRT services here. One doctor said that I like that they can address the main reason why the patient is here, refer them to the interventionist, and don't interfere with the flow. And I think this kind of harkens back to my initial point a little bit ago to talk about when could we fit in as SBIRT services in a way that was as least disruptive to the other services that the patient was seeking at the clinic. And then lastly, another physician said that SBIRT shows patients we care, and one not just going to look at their penis and send them on their way. So we thought that was kind of a funny one. So I guess as a final slide, I'd like to kind of leave you with where we are in terms of thinking about our challenges and future needs for SBIRT services in our clinic settings. What we know is that in terms of clinical care, we have a very high volume population and we have a very high need population. We know that about 51% of our clinic population pre-screens positive, and we know that we're really only able to see just under half of those, maybe 40–45%, to even provide them the full screen and the intervention. And that's even with a full-time dedicated staff person at each of our sites. And so I think we know the need is there, and it's a question of how to prioritize staffing and how to prioritize our patients to make sure that as best as possible we're trying to see those that we think may be at higher risk. Another clinical care challenge is just retention in extended brief intervention. As I mentioned, we only see about, of those that we refer internally to EBI, we see about a quarter of them that come back for those services. What we're working on right now is some improvements to those follow-up procedures and analyzing some of those data and really doing some quality improvement around making sure that people get a minimum number of reminder phone calls before their appointment, and then also follow-up phone calls if they had missed their appointment. And finally, linkage to substance abuse treatment. We, in the future, would really like to evaluate some of these retention factors. We do have as I mentioned, we found about 42-odd% of patients do actually link to substance abuse treatment, and we feel that's actually slightly higher than it was when we were doing the Project Link project. And I think part of that is because we are able to offer these extended brief intervention services, so perhaps patients who really are not quite ready to accept a formal treatment referral, or perhaps have been in treatment in the past and are not ready to be abstinent, those folks are maybe more likely to accept a referral to extended brief intervention. And so therefore, the ones that do take the treatment referral are more likely to link to treatment more permanently. And then finally, I think the kind of elephant in the room for us right now is really sustainability. This grant, we have about 2 more years of funding in this federally funded SAMHSA grant, which supports the vast majority, almost all of our staffing for this SBIRT program. And we really need to think through alternate funding sources, potentially additional grant funding, as well as billing for SBIRT, and we're looking toward billing for SBIRT in the coming year. We've just started billing for some other STD services that we provide, so that billing for SBIRT is sort of in line with where our Bureau is headed in terms of service provision. And then also potentially thinking through alternate SBIRT models. I mean, as I mentioned, we have specified dedicated SBIRT staff and mental health staff that are at each of our clinics. And, is there a way, if we don't have quite the funding to support that amount of staff, is there a way that we could use existing staff to provide some of these SBIRT services? So we're sort of thinking through a lot of those processes, and you know, we're looking forward to the future. So I guess at that point, these are references and some contact information, and Shirley and Brett and I would be happy to take any questions from the audience.
Okay, thanks so much. I will just take the screen back now. So let's see, is this me? Yes. Okay. Yeah. So you can see my screen now. I'll put up the questions. Yes, I had one question that dealt exactly with what you just went over. And it is, was there a reason why existing staff was not cross-trained to provide the brief interventions? In smaller practices, it would not be feasible to hire a person to exclusively provide BI and RT.
Mm-hmm. I don't think there was a specific reason why we couldn't have cross-trained staff. And in fact, we actually did cross-train a number of staff initially about 6 or 7 years ago in motivational interviewing. But I think that one of the main reasons really had to do with funding streams. So some of the staff that we have that do a lot of our partner services work, which is interviewing patients to ask about sex partners and following them in the field, those were the folks that got motivational interviewing training. But we're, you know, they're funded by CDC for totally sort of different workload and are responsible to CDC for ensuring that that workload is done. And so when we initially started thinking through this, it was in partnership with OASAS, and we decided to apply for grant funding where we were lucky enough to get some funding to support staff that could do this. And I think, you know, it did make a big difference, especially at the beginning, that we had outside staff that were able to do it. I think it made it a little bit of an easier sell to our staff, to both our physicians as well as to our public health advisors, that they could be working collaboratively with these people, but they wouldn't have to take on an entirely new service delivery. And I think that also our physicians were receptive to that, because many of them initially felt sort of like it was out of, not just out of their purview, but out of their comfort zone and skill set to be able to provide some of these, you know, motivational interviewing SBIRT services. But now that, you know, now that we're multiple years down the road with this project, I think the staff are much more familiar with it, much more comfortable with it, and at this point would be much more receptive to, you know, getting some of that training and perhaps providing some of the services themselves.
Okay, great. I'm going to unmute Shirley and Brett too, so that they can join in on answering any of these questions. So Shirley and Brett, you are unmuted also. The next question I have is, does the EMR identify patients who have already been pre-screened at some point in the past? It seems like it would be mighty tricky for IT folks to set that up. Or do the clinics rely on the patients to say, I've already did this last year?
Right. So the answer is kind of both, actually. The EMR, the system that we have, is that anybody who works in the clinic could go into a previous visit of that patient and determine whether or not that patient was pre-screened and what their screening results were. However, for that particular visit, when the patient shows up, it's just that visit that's usually on the triage page and is in the screens that staff typically look at. So a lot of times, I mean, we certainly have patients that will do the screening a second time. And as I mentioned, there's about 22% of our patient population that does not fill it out. And the vast majority of these patients that don't fill out the pre-screen are persons that have already pre-screened and screened negative in the past. So that's partly relying on the patient to, you know, self-identify as having screened in the past, but that we could look up the information if we needed to.
And somebody earlier asked, what is GPRA, G-P-R-A? I actually Googled and found a statement that I put in here, but I thought you could fill it out a little bit more. I just said it was the Government Performance and Results Act, and that it is loosely viewed as part of the administration's larger Reinventing Government initiative, and it's required for SAMHSA-granted SBIRT services at clinics and health care centers.
Brett or Shirley, do you want to add to that?
I'm just hearing a lot of dead air there.
Not really. I mean, that pretty much answers everything. Yeah, that answers everything that we have. We are going to have to get off a little bit early. So I think we're going to have to get off right now, Chris.
Yeah, that's fine. Yeah, you can go right ahead. I'll just.
Okay, I'm sorry.
Oh no, that's fine. Thanks so much for participating. Okay.
Okay. Bye bye.
Okay. Bye. So
just to add to what you said about GIRPRA, the only other thing I would mention is that it's about a 16, 17-page questionnaire, and that everybody, for the purposes of our project, when people initially are enrolled in SBIRT and receive a service, they have to complete some component of that questionnaire. And then if they are part of the 10% sample that is enrolled in the 6-month follow-up, they have to complete it again. And that's the way, SAMHSA's way of comparing outcomes over time.
Yeah, we do have, excuse me, one attendee who said it's a very long questionnaire.
Yeah, it's long.
And actually, everybody, our evaluation that we ask you to complete at the end of the webinar is also called the GIRPRA form. It's nothing like what they use at the STD clinics. It's just an evaluation of the webinar and the services that we provide under our government-funded grant. So that's also a GIRPRA. So they do vary. Well, thank you very much. That's the last question I have here. So thank you, everybody who participated in this. It was very informative, and again, this will be put on our webinar library by tomorrow morning. So thanks a lot, Megan. I'll close you out now, too, so you can put away all your stuff. Thanks. Bye-bye.
Thank you.
Okay, so just in the last couple minutes here, I'd like to just show you what our webinar, or what our National SBIRT ATTC homepage looks like, and all the information you can get here. Again, we are the National SBIRT ATTC, and it's part of a nationwide grant funded by SAMHSA. There are locations all over the country, and we are one of the 4 that are funded for a nationwide grant. So we're on SBIRT, and then there's other topics too. This is our home page, and we have things like this is the latest blog from Dr. Wesley Clark. You can click on that and read that. We have a bunch of these digital tours, which are really short 3 to 5 minute videos on a topic of our choice, and this one's on the CDC new 10-step implementation guide, and you can get the whole guide by clicking here and downloading it. Also, if you'd like to see if the SBIRT services and SBIRT are up in your state for billing purposes, you can click on the map. It'll take you to a larger map where you can click on your state and get all the information on the SBIRT codes and services that are up in your state. We have a few infographics around too that you can click on, and there's a lot of information there. We have products and resources. We also have a trainer directory if you're looking for somebody to train on SBIRT or a variety of other topics in your area. Just click on the map for your region, and you will see the names of the trainers located there. Click on the name of the trainer, and you will get all their information that they provided to us. So that's information that can be very helpful. E-News, there's SBIRT Alert newsletter that comes out approximately once a month or so, and you can see the latest newsletter just by clicking on this link, and also subscribe to it if you'd like to get it. These are SBIRT-specific topics of interest. So we are lucky to be partnering with NORC at the University of Chicago. They also offer trainings and webinars, and they have some webinars listed here. Their webinars are also stored on their site, and you can view those. Distance learning, if you're interested in any online courses. This is our brand new one that we started just a month or so ago, SBIRT for Adolescents, and we'll have another one coming up here shortly. So these are all items that you'll be able to see from coming to our homepage. Now, if you'd like to see where the ATTC is for your region, we also have a link to that. And again, you can just click on your part of the country here. It takes you right to the ATTC that covers your state. So you'll be able to contact them with any information you'd like them to supply you. You can also see all the highlights and resources they have available and the trainings they have. So this is also a very interesting site, and to see what other states are offering. This is one for the Southwest. So we just wanted to take you on the brief tour of this of our website. Sorry, I'm trying to do two things at once here. And we hope that you'll visit it soon. I will have the link in the email that everybody will receive in the morning. So I think that concludes the webinar. Thank you very much for attending, and be on the lookout for the email with the evaluation and the email tomorrow morning with the CEU certificate and the link to the slides. At this time, I'll say goodbye to everybody, and we hope you'll register for another webinar soon.